Good morning, everyone. I'm Dr. Asif Almas. Today, we are going to discuss about a case of rectal cancer. We will have a more of a clinical approach, the approach that is necessary in the world, and we will go from that. So, a case of rectal cancer. At first, we start with the particulars of the patient. Particulars of the patient, particular importance is the age. Now, I have taken most of this information from Bailey and Love. You can also go through that book. I think that's very standard, and it has got good information regarding rectal cancer. So I think you guys all should go through the rectal cancer chapter from Bailey and Love. That's why it's written that usually most of the patients are above the age of 55 years, but it can occur at any time in the adulthood. Now, as a colorectal surgeon, I see multiple rectal cancer patients each and every day. And it is most interesting to say that nowadays, at least 30 to 40% of the patients are below the age of 55 years. Some are even as low as 25 years and 30 years old. It maybe has to do something with our what the our food habits, all this formalin and different types of chemicals that are being added to the food may have some effect. Now, sex of the patient, definitely like all solid organ malignancies, like most of them, male are more predominant, but in my experience, I see male and female patient equal in number. Now, chief complaints. What are the most important features of rectal cancer? This is very, very important, and you make sure that you write it in the correct order, at least in the order of, in chronological order, or in order of severity. First of all, bleeding during defecation. You can also write parectal bleeding, but which is slightly more medical in terms. So some examiners may have some complaints about that. I think bleeding during defecation is a more accurate term that you should use. But definitely, if you want to use parectal bleeding, I don't think that's a big problem. But make sure that you understand the examiner and what he is looking for. Sense of incomplete defecation. That means after defecation, there is always a sense that more stool is remaining in the rectum or you have not cleared everything. And occasional diarrhea. Now, what is the cause of the bleeding during defecation? Now, if you look at the rectum, rectum is something like this. It's sort of a conical organ, and then comes the anal canal, right? Right. Now, where is the bleeding coming from? For example, you all know that the rectal cancers may be ulceroproliferative. So if there's an ulcer, something like this, now you know that this ulcer will invade into the blood vessels. As a result, there will always be some bleeding. Now, interestingly, this is not a massive bleeding. Usually, small amount of bleeding happens. Usually, small amount of bleeding that takes place, which is scanty. If a patient says, I have a large profuse bleeding, it is usually not a rectal cancer. It's usually scanty in amount. Remember that. Now, this blood comes out. Now, if you are defecating right at this moment, this fresh blood comes out, and you'll see that some fresh bleeding is happening. Fresh bleeding, number one. On the other hand, sometimes this bleeding stays in the rectum for hours, and it becomes clotted. Mixed with stool and a bit of mucus. And after then it is passed. So this time the bleeding is actually not fresh or bright red in color. It may be dark red or clotted, and mixed with small amount of mucus and stool. This is the pathophysiology of the bleeding. So what you have to understand that in the bleeding of rectal cancer, there is no specific type of bleeding. Blood is present there, but it may be fresh blood, or it may be clotted blood, or it may be mixed with mucus or stool. Any of this is possible. For example, in hemorrhoid, the bleeding is always fresh blood. You see fresh blood, drops of blood are dripping down. Now it comes a sense of incomplete defecation. Now, as you know, if there is a tumor or there is a malignancy in the rectum, as you know, the rectal mucosa is highly sensitive to all sorts of foreign bodies. It is highly sensitive to all sorts of foreign bodies in the rectum. Now, remember, this is also a foreign body. The tumor in the rectum is a foreign body. It may be a polypoid tumor, which is cauliflower-like. It may also be ulcerative, but whatever it is a foreign body, and the rectum regards it as a foreign body, and the rectum is always trying to expel this foreign body out of the rectum, but it always fails. Now, this foreign body gives the sense of incomplete defecation, the sense of incomplete defecation. Always there is a sense that there is something in the rectum, but actually there is nothing in the rectum, no stool is there. The foreign body that the rectum feels is actually the tumor. Now, the rectum is trying to expel this tumor, but it cannot because it is attached to the rectal wall. So, the patient will go multiple times to the toilet to expel this tumor, but you will not succeed. And this causes pain. This may cause pain for this patient. This is actually the term that is used for this is called tenesmus. That means painful urge to defecate without any resultant evacuation. The patient is trying to defecate something, the patient is trying to evacuate something, but it cannot. It's not successful and it causes pain. If it is a polypoid tumor, there will be severe pull on the pedicle of the polyp to expel it. This may also cause pain or distress to the patient. Now, then another term that has been used is the occasional diarrhea. I'll come to you a little later about that. So what do we see here? The presenting illness can be something like this. You can definitely customize or personalize in your own way. According to the statement of the patient, he was reasonably well about 4 months back. About 4 months back. He noticed bleeding during defecation. Bleeding is small in amount. It is painless. Now remember, why did I say painless? Now remember, the commonest features of the commonest complaints, the commonest pathologies that we see in rectum and anal canal are fissure, piles, fistula. These are the commonest things. That's why to differentiate between the bleeding of a fissure, to differentiate between the bleeding of a piles, we are asking this question. Because in piles, the amount will be large, not small. And in fissure, it will be a painful bleeding, right? Which is bright red in color. Now listen to this. This is bright red in color, but occasionally it is clotted, mixed with stool and mucus. Occasionally it is clotted, mixed with stool and mucus. Okay. For the last 2 months, he is also having a sense of incomplete defecation. Sense of incomplete defecation. He also complains of diarrhea for 2 months. He painfully strains only to pass a small amount of blood mixed mucus and stool. He has to repeatedly go to the toilet about 7 to 10 times. This is very important. 7 to 10 times. He has to repeatedly go to the toilet 7 to 10 times. Now, it is important only when we know what is the normal frequency. That is, the frequency previously, he had to pass bowels only 1 to 2 times a day. So as you can see, this is one way of alteration of bowel habit. I'll come to you in a very short time. He gives no history of abdominal pain, distension and vomiting. Why did I take this history? Because at this moment I am thinking of rectal malignancy, and also I'm thinking whether it is an advanced malignancy that has obstructed the lumen completely, which will result into intestinal obstruction. That's why I've asked this question. Did you ever have abdominal pain, distension, vomiting, or constipation? He did not have it. So this shows that it's not an obstructive lesion, probably not an advanced lesion. His bladder habit is normal, no loss of appetite or weight loss. And remember one thing, in rectal cancer patients, very, very rarely, until and unless it's a very advanced cancer, there's no history of loss of appetite or weight loss. He has no fever, jaundice, cough, headache, or bone pain. I'm taking histories of any metastatic features, and he had no other significant systemic symptoms. So now, what are the complaints that we can see? The complaints are, number one, the patient complains of bleeding, right? Let me see this thing. Okay. First of all, it is bleeding. Now, I have discussed why there's the bleeding. If it's an ulceroproliferative, it's an ulcerative growth, usually that is when the bleeding takes place, number one. Number two, there is a sense of incomplete defecation. Why? Because the malignancy is regarded as a foreign body by the rectum, which is always trying to expel, but there is no success. It always fails to expel it. Now, the small amount of blood mixed mucus and stool, this diarrhea, how is this happening? Or sometimes some of you say alteration of bowel habit. What does it mean exactly? Now, if this is the rectum, if this is the rectum, now remember, if there is a growth over here, it will slowly increase in size, right? Or if it's an annular growth, it will increase in size and ultimately it will try to obstruct the lumen, right? So what happens whenever stool is over here, they get obstructed, right? Now, this causes the constipation. In some rectal cancer patient, they say, I cannot defecate at all. Especially this happens in case of annular growth or very advanced cases. This is the constipation. Patient will say, sir, doctor, I never had this as a problem. I used to go to the toilet 1 to 2 times and pass normal stool. But recently, for a few days, what is happening is that I am having difficulty in passing my stool. I'm passing hard stool. So this causes the constipation. Now, what happens? You understand, there is the rectal mucosa is always secreting mucus, right? Right. So this mucus is diluting and liquefying some of the stool, and some of the stool escapes from here, and it usually forms a little bit of liquid stool plus mucus and sometimes blood. And when this is passed, the patient says a small amount of diarrhea. That's what happens. Now, we as doctors, we know that this is not diarrhea. This small amount of liquid stool which is being passed, this is not exactly a diarrhea. This is called fake diarrhea or spurious diarrhea. This is called the spurious diarrhea or fake diarrhea. And sometimes what happens is when the patient is sleeping the whole night, this liquid stool gathers over here. And when the patient wakes up, the patient has intense urge to go to the toilet. And the patient goes to the toilet and passes this small amount of stool mixed with mucus and blood, or this diarrhea. This is called early morning diarrhea. So these are the specific features of rectal cancer. Number one, bleeding during defecation, tenesmus, spurious diarrhea, or early morning diarrhea, or alteration of bowel habit, which happens. Okay, let's go forward. Disease history. Certainly, you will take all sorts of history about other diseases, but today I'll only discuss about diseases related to rectal cancer. So, for example, you can ask the patient about history of polyps. Did he ever have polyps? Because polyps have a tendency to turn into malignancy. Or other colorectal diseases like ulcerative colitis. If you remember that ulcerative colitis has a small chance of turning into malignancy. So take history of that. If patients can't say anything, take history that did you ever have any abdominal or colorectal problems. Even the patient can't say anything, patient will be able to say that I've been having dysentery for a long time. I pass blood with my with diarrhea. So that gives you an idea that patient may have some form of colitis. Personal history of colorectal cancer, ovary and endometrial and breast cancers. Now there are familial cancer diseases like familial adenomatous polyposis coli or HNPCC, hereditary non-polyposis colorectal cancer. In this case, no polyp is found. Okay, it directly goes into cancer. So these are the things I will, if I get another chance another day, then I will discuss in greater details about these diseases. But today we will have to finish this chapter. Okay, treatment history, again, history of polypectomy. As usual, association with smoking, alcohol, and high fatty diet. Some people say that high fatty diet has an association with different types of malignancies and also with rectal cancer, because this fatty diet can form some toxic chemicals like free radicals, which have a tendency to mutate the DNA, and as a result, it may result into malignancy. Family history of colorectal cancer, history of FAP and HNPCC, you must take this history. Obstetric menstrual history, if the female patient must take this history as well. Um, I just want to remind you just a practical problem which once we faced. Sometimes some female patient comes to you saying the patient has pararectal bleeding. Now, sometimes some females cannot differentiate between pararectal bleeding and paravaginal bleeding. Okay, so it is very important that you be able to differentiate it as well. Sometimes I have seen in my life that even this thing also happens. Some female patient, whatever, some paravaginal bleeding during or menstruation, or and some other times patient was confused whether this is pararectal bleeding or paravaginal bleeding. So make sure in a female patient you always do a paravaginal examination as well. Awesome. Immunization history, vaccination, again TB, we must take the history of TB in all cases. General examination, most of the times in my practice what I see is most of the patient with malignancy in the rectum are very normal looking. They don't even have any weight loss or anything. Only thing they may have is anemia, because some patients have been losing blood for a long time. If I have never seen this, but if the patient have hepatic metastasis, then it may happen. I have never seen in my life, but you must talk about jaundice. Check it out. Hydration status and other things you must take care of. Abdominal examination, usually you do not get anything. Usually what you may get is ascites. If there's liver metastasis, may get a nodular liver. You may get an abdominal mass. What happens is it's a very advanced case, and it is usually in the upper rectum or the rectosigmoid junction. You usually get some mass over here, in and around here. You may get a mass which is arising from the upper rectum. Lower or mid rectum masses never really reaches this far, because before that there's obstruction and other problems, and patient always having those sort of problems. Okay, next. must palpate the liver. Okay. Digital rectal examination, most important. This is the most important part of rectal cancer. Long cases. This is the part the examiners are waiting for, what you say. Now, first thing is how you do. What is the position? What are the prerequisites? What do you need? For example, certainly you need an indication for that, right? You cannot just tell anybody that I'm going to do a parectal examination in you. Patient will say, I'm having such and such problem, and then you will do the examination with his permission, right? You will provide privacy. You need a good light, right? You need gloves. You need jelly and other instrument like proctoscope, right? So, and many other things, whatever you need, but must talk about the patient. Must take a permission from this patient. ঠিক আছে? What you must say, you can say যে আসসালামু আলাইকুম, আমি ডক্টর এক্স ওয়াই জেড, আমি আপনার মলদ্বারের যে সমস্যা আছে সমস্যাটা একটু পরীক্ষা করে দেখতে চাই আমার আঙ্গুল দিয়ে। আপনি আশা করি কোনো ব্যথা পাবেন না, তবে একটু অস্বস্তি লাগতে পারে। আমরা আপনার প্রাইভেসি সবসময় মেনটেন করব। আর হাউ ইউ আর গোয়িং টু ডু ইট, টেল দেম যে এভাবে এভাবে করবো, একটু অস্বস্তি লাগবে, ভয় পাওয়ার কিছু নাই। ঠিক আছে? And then with the permission of the patient and providing adequate privacy, you started. Ideally or usually we do it in the left lateral or Sims position, right? But you can certainly do it in the dorsal position, in the lithotomy position, or in the knee elbow position. These are some of the pictures with the names. The Sims or the left lateral position, the lithotomy position, this is important, dorsal position. These are the three positions. Just remember only these three. This is a squatting position. What do we check in the squatting position? Rectal prolapse. Usually no other, for other reasons we do not need it, but rectal prolapse and hemorrhoids. You can sometimes, patient's history is confusing, and to differentiate between rectal prolapse on 3rd degree or 4th degree hemorrhoids, you can check it in the squatting position. In sitting position, actually you can do any examination. Standing position, sometimes you need it to do some examination. So what are the things you look for? For example, if this is the rectum and this is the anal canal, and here is the malignancy. So you insert your finger over here. First thing what you want to find out is the distance of the lesion from the anal verge. What is the anal verge? This is the skin of the anal canal that you can see. This is called the anal verge. When the anal canal is closed, the skin the corrugated skin that you can see is called the anal verge. So you start your measurement from the anal verge. Usually what you should do is measure your own fingers. That way you can have a pretty good estimate of what the distance is. For example, my index finger is about 7 centimeters, and I think this is at an average, this is the length of most people's index finger. So when I find something with my index finger, I can say it's a 7 centimeter lesion. A lesion is 7 centimeter from the anal verge. Macroscopic type, that means what type of lesion is this? You know, the rectal malignancy can be, it may be an ulcerative growth, it may be a polypoid growth, it may be an annular growth, or it may be a tubular growth, right? There's some very nice pictures in the Bailey and Love. Just have a look at those pictures. You understand what I'm taking. Again, it may be an ulcerative type, it may be a polypoid or cauliflower type, it may be an annular type, or it may be a tubular type. So if you can find it out, try to find out what type is it. So in this case, it's an ulcerative type with raised and inverted edges. Upper limit, can you reach the upper limit? Most of the times we can't. Most of the times we can't until and unless it's a very low tumor. Fixity to the surrounding structure. This is a sign of advanced disease. It's very, very important. Fixity, it's very, very important. Fixity shows whether it is fixed circumferentially, how much the growth has extended. Has it extended to the surrounding structure like prostate, like sacrum? You must find it out. Fixity to the underlying structures. Tenderness. Why tenderness? If it's an inflammatory lesion, it may be tender. If it's an advanced lesion, it may be extremely tender. So tenderness in a rectal malignancy is again a sign of advanced disease. Blood-stained finger. Usually if it's an ulcerated lesion, you will see that there is the finger on withdrawal becomes blood-stained. In female patients, remember to do a vaginal examination. This is very, very important, because sometimes if this is the rectum and if this is the vagina, and anterior wall tumors may invade into the vagina. This is again a sign of advanced disease. So you do a parvaginal examination as well in case of females. So salient features. Remember that salient features must be as short as possible with as much information as possible. You give both negative and positive findings. Important negative and positive findings. For example, what's a sign of important positive finding? Bleeding is a positive finding. What is a negative finding important? Painless is an important negative finding. So remember this thing. You must give important positive and negative findings. So how did I write it? Mr. X, 72 years, a farmer from Borishal, was admitted to this hospital on the 20th of last month with the complaints of painless pararectal bleeding, during defecation for 5 months, tenesmus for 3 months, and spurious diarrhea for 3 months. Now, I have discussed all of these terms and how this is happening. If you do not understand, you can just tell me. I will again discuss this. And he has no history of intestinal obstruction. Why did I take this history? To understand, is it an advanced malignancy or not? Because one of the signs of advancement is intestinal obstruction or any metastatic features. On general examination, only the patient is mildly anemic. Usually you get severely anemic patients if it is a cecal malignancy or malignancy from the right colon. In rectal malignancy, as because the patient sees the bleeding, patient usually comes to the doctor at a very early stage. Usually. On abdominal examination was normal. On digital rectal examination and tender, ulcerated lesions with raised everted edges was found at 7 centimeters from the anal verge. Fixed to the surrounding structure or may not be fixed, you tell whatever the finding is. Upper limit could not be reached, finger was blood stained on withdrawal. So all this gives you a history sign that the malignancy is probably an advanced disease, right? It is fixed, it's advanced. If it is not fixed, it may be advanced, it may not be advanced. Or even if it is fixed, that means the chances of being an advanced malignancy is high. So the provisional diagnosis is carcinoma rectum. Provisional diagnosis is carcinoma rectum at 7 centimeters. You can add advanced if you think. Advanced carcinoma rectum. Sometimes you can also write inoperable in the bracket, which gives you an idea that what your plans should be and will be. But if it's a fixed tumor, if it's a large tumor, you can add advanced carcinoma rectum and the distance is at 7 centimeters. Differential diagnosis according to finding. Remember this, you don't have to write all these differentials. If you are very sure about the diagnosis, write rectal cancer. But if you have some confusion like rectal TB, inflammatory stricture, amoebic granuloma, solitary rectal ulcer syndrome, and ulcerative colitis. Now, I have seen that many times we have confused rectal cancer with cases of advanced ulcerative colitis disease or even solitary rectal ulcer syndrome. Now, I will, if I get chance in the future, I will discuss about these diseases. These are very important, and you must be able to differentiate these diseases from the rectal malignancy, because both of these diseases have parectal bleeding. And sometimes all the features are same. So it has to be differentiated from rectal cancer. So how we assess? We first need to confirm. We first want to confirm our diagnosis. If it is a malignancy, then we need to stage the disease, assess whether it is operable or not, and general assessment for surgery. So how do you take the biopsy? Now remember, it's a 7 centimeter mass. The mass is somewhere over here. So you do a biopsy from it. Remember, if this is the mass, if this is the ulcerative lesion, what we try to do is try to take the biopsy from all the 4 quadrants, especially from the periphery, and then some from the center. But always make sure that you have enough tissue. If you don't have enough tissue, you take 10 biopsies as well. If you have enough tissues, 5 to 6 samples are okay. How do you understand if you have taken enough sample or not? There will be bleeding. Once you take a bite, there will be bleeding. If there is no bleeding after the bite, and then you will understand that you have not been able to take enough tissue. So when there is bleeding, then you can take 5 to 6 bites from different quadrants. Now, next investigation that we need to do is a colonoscopy. Now, why colonoscopy is necessary? Now, remember, we can certainly take the biopsy with a colonoscopy as well. But in the examination, if it is a low rectal cancer, always say that I would like to do a proctoscopy and take the biopsy. And then I will go for colonoscopy, because in that case, if the cancer is over here, let's say, you don't need a colonoscopy to do it. A colonoscopy is about 1.5 meters long. So you don't need to use a 1.5 meter long instrument to take a biopsy from a tissue which is just 1.5 centimeter from the anal ward. Now, if it is in the upper rectum, you can do a proctosigmoidoscopy and take the biopsy. But anything above that, colonoscopy is the ideal investigation to take the biopsy. But there is another very important reason for the colonoscopy. That is, there is a chance that there may be synchronous tumors. Synchronous tumors means at the same time there is 2 or more tumors that is coexisting. For example, one tumor may be in the rectum, another tumor may be in the ascending colon. This thing happens, especially with patients which has multiple polyps. Also, if the patient has, you must check whether there's any polyp in the rectum or colon before doing the operation, because then you can plan the treatment accordingly. Because in my case, I have seen this problem in a patient who had an obstructive lesion, in the I think if I remember, in the rectosigmoid junction that patient had just a few days back even. And we could not do a colonoscopy in this patient due to obstruction. The scope could not be passed. Now, what happened is, even in the CT scan, no specific finding was there, but there was a very small cancer in the ascending colon. So naturally, we did not do laparoscopy for this patient, but we had no idea the patient had another tumor. So we did an open surgery because it's advanced disease and obstruction. And during the operation, we palpated the whole colon. And during palpation, we found out that there is another cancer in the ascending colon. So we had to do a total colectomy for this patient. Total colectomy and then iridorectal anastomosis. I'll discuss those things later, what we did for this. These are very advanced discussion. We don't need those discussions right now. Okay, so in a nutshell, what are the other investigations that we do? So we have confirmed our diagnosis, right? Confirmed our diagnosis with biopsy. Now what we want to know is how much the tumor has spread. So we want to stage the disease. In Bangladesh, as because most of the places the advanced investigations are not available, that's why I always say these 3: ultrasonogram of whole abdomen, chest x-ray, and liver function test. These are the basic investigations that we do in all malignant cases of the abdomen. Why CBC? Because the patient has anemia, right? So we do a CBC. But the most important investigations are these 2 for staging purposes. the CT scan of chest and the abdomen, and MRI pelvis. Now remember, in rectal cancer, always talk about MRI pelvis because this gives you a lot of information about the operability, about the advancement of disease, about any lymph node metastasis. CT scan of chest and abdomen. Why do we want to do a CT scan of chest and abdomen? Because it's a very, very good investigation to assess intra-abdominal and intrathoracic metastasis. For example, if the patient has liver metastasis, if the patient has ascites, then you can do that. If the patient has ascites, then also you can do that. MRI pelvis is most important finding that is necessary is to check the circumferential margin of the malignancy. I'll come to you in very late shortly. Another investigation that can be done is transrectal ultrasound. This is also important for finding out the circumferential involvement of the tumor. The circumferential involvement, what this means, if this is the rectum in the axial section and if this is the tumor, right? The tumor is growing also outside, right? And let's say this is the mesorectum. So how much the tumor has involved? For this, the MRI pelvis and transrectal ultrasound are very, very good investigations. PET scan you can do for checking out other metastases in other parts of the body, also to assess the prognosis and outcome of chemoradiotherapy and radiotherapy. But it's a very expensive investigation, the PET scan. Ideally, you will not talk about it in your examination, only when the patient examiner asks. Another very important investigation is diagnostic laparoscopy. Let me write it here. I forgot to write it. Diagnostic laparoscopy. Because this is the only investigation that can show peritoneal seedling. Peritoneal seedling. No other investigation, not the MRI, CT or transrectal ultrasound or even the PET scan, none of it can show you whether there is a peritoneal seedling or not. Only diagnostic laparoscopy. So remember, any intra-abdominal malignancy, don't forget to say diagnostic laparoscopy as one of the investigation for staging. Okay, so see in CT scan, what do we see in CT scan? As you can see over here, let me change the color a bit. Okay. As you can see, if this is the rectum, look at this. This is the rectum. And this is the malignancy. Very nicely shown. CT scan. Liver metastasis in CT scan. Again, you can see it over here. Multiple liver metastasis. It's a very advanced disease. This is chest metastasis. Multiple. It may give you a cannonball appearance in chest X-ray. Now, can you see what's the finding over here? Should be. Look at this. This is ascites. Huge ascites. Another finding, very important. Sometimes, if it is a rectal malignancy, upper rectal malignancy, it may involve the ureter. And as a result, whenever the ureter is going from the kidney to the bladder, it gets obstructed and it becomes hydroureter and hydronephrosis. This is again a sign of obstructed lesion. What should you do in such a case? In such a case, you must always consult a urologist. The urologist will put a stent through here so that perioperatively you do not injure the ureter. Or even if you injure the ureter, make sure the urologist is around who can repair the ureter. Okay, MRI pelvis, very, very important. Now look at this. This is the rectum. This is the mesorectum. This is a normal finding. Okay, rectum. This is the mesorectum. These are the seminal vesicles. This is the prostate. This is the bladder. Okay, let's go. Let's see what we can find. And now look at this. This is the rectum. Sorry. Now look at this. This is the rectum. And this is the ulceroproliferative growth over here. Now look at this. The growth has extended all the way over here. Very clearly it can be seen. Now, if you look at the mesorectal margin over here, you can see the mesorectal margin, the cancer is very close to the mesorectal margin. Now, if this distance is less than 1 millimeter, or if you think that this margin has been involved by the tumor, then you must send the patient for chemotherapy. This is called neoadjuvant chemotherapy, or neoadjuvant radiotherapy, which is neoadjuvant means it is given before surgery. It's given before surgery so that the tumor shrinks and you have a better margin for clearance, right? Tumor shrinks and you have a better margin for clearance. This is very, very important. Again, I am telling you, why do we do the MRI? MRI is to see the local advancement of the disease. Most importantly, the circumferential involvement of the tumor. Most importantly, we do this to check the circumferential involvement of the tumor, right? So, okay, another important finding. If you see, this is the rectal malignancy, very low rectal cancer, right? And this is the muscle, anus, right? So it is very close to the muscles. So in this case, this is very low rectal cancer and involvement of the muscle. As a result, in this patient, the total rectum with the anal canal has to be thrown out. It has to be excised. And this is called APR operation, or abdominoperineal resection. I will discuss this later, just now. So MRI is very, very important. It can show both lateral or circumferential involvement and longitudinal involvement of the tumor. So this is a very, very important investigation. And transrectal ultrasound. This is also another investigation which gives you an idea of the circumferential involvement. If you look, this is a normal finding. This is normal. You can see the different layers of the rectum, and now you can see the tumor. Have a look at this. This is the tumor, and you can see the layers it has involved, the submucosa, the muscle layer, and the cells, and the other layers that has been involved over here. You can also see the other structures like seminal vesicles. So one is over here and another one is over here. So these are very, very important investigations, and PET scan. Okay, so what do we do? So when we get a rectal cancer, what the first investigation we want to do is a biopsy, right? To confirm the diagnosis. Then we do a colonoscopy to check whether the colon is clear or has a synchronous tumor or not, or any other polyps. Then we check the local advancement of the disease by MRI pelvis or transrectal ultrasound. And to see the distal metastasis, we do a CT scan of abdomen or chest. And any other metastasis like bony metastasis, we can do a PET scan, which we rarely do. In Bangladesh, we do it nowadays, but it's very expensive investigation, very, very expensive. So we rarely do it until and unless absolutely necessary. Another investigation that we do is the carcinoembryonic antigen. What is this? These are complex glycoprotein which are produced by embryonic tissues. Mostly 60 to 95% times it is from the colorectal cancers. But this is not, remember that this is not a very specific or very sensitive or specific. This is neither very sensitive nor specific, because other causes are there as well. So, but it gives you an idea whether it's an advanced disease or not. And also you should do it because, for example, you do a CEA level, right? At baseline. Let's say at baseline, the CEA level is, let's say, 11. If you look at this, just let me show you. The normal CEA level is below 5 nanogram per ml. So let's say during in certain case, the before operation it is 11 nanogram per dl. you check it after operation. A few days or 1 or 2 months after operation, you'll probably see it becomes 2.5. So you mean definitely the tumor has been removed and it has downstage. After chemotherapy, you again check and you'll probably find it at 1.5. So it means chemotherapy is working. After 2 years after operation, you see that it becomes 7, then it becomes 11. So this is a sign that the cancer is recurring. That's why to see the prognosis of the disease or the effect of treatment on the disease, you need to have a baseline. The baseline level of the CEA. Staging, very, very important. Must know this thing. This is T1 means limited to mucosa and submucosa. T2 means it has reached. If this is the mucosa, this is the submucosa, and this is the muscularis layer. Let's say this is the serosa, and this is the mesorectal fat over here. So when it is mucosa and submucosa, this is T1. If it has reached but not breached. If it has just reached the muscle layer, it is T2. It has extended beyond the muscle layer into the perirectal fat, it is T3. And it has extended to the surrounding tissues, it's called T4. Remember, both T3 and T4 are these are advanced malignancies, and ideally at this level you should go for neoadjuvant chemoradiotherapy, which will ultimately downstage or make the tumor smaller, and then surgery would be more possible. And this is the N levels and the metastasis. Duke's classification nowadays not very much used, but always asked in the examination. Duke A means it's still limited within the bowel wall. Duke B has beyond the bowel wall, but no lymph nodes. Duke C means lymph nodes. Duke D means widespread metastasis. That means if this is the rectum and if this is the tumor, if it is limited within the bowel wall, it is A. If it is extended beyond the bowel wall, but no lymph nodes, this is B. If it is extended beyond the bowel wall and lymph nodes are also involved, then it is C. And if it is beyond the bowel wall and has metastasis into the liver, then it is D. Very simple to understand. So after all this, we have confirmed that that is a case of carcinoma rectum at 7 centimeter. Carcinoma rectum at 7 centimeter. So what are we going to do? We will treat this patient. How are we going to treat this patient? Treatment will depend upon the stage of the disease. What we are going to do depends on the stage of the disease. For example, stage 1, stage 2, we go for surgery. Stage 3, we discuss with the oncologist whether surgery would be the best option or chemotherapy. Stage 4, usually we go for chemotherapy. So this is how we usually plan the things. But this is not as simple as I have said. There are many other factors that come into play. Let's see if I can discuss some of those. But there should always be a multidisciplinary approach. That means different professionals should be there. Number one, of course, the surgeon. Number two, the stomach care nurse, because if you remember, there is a chance that you might need a stoma. So a nurse is very, very important. Oncologist, radiologist, pathologist, gastroenterologist. If you need anyone else, for example, a psychiatrist, you may add them as well. Whatever you need, you talk about that. Now here is most important part of this discussion. Now remember, in case of a rectal cancer, why rectal cancer is different from all other parts? If you remember, in case of rectal cancer, the anal canal is very close, right? And there is a chance that you might lose the anal canal. And in such a case, there will be a permanent colostomy in this patient, right? A permanent colostomy will be there in the patient's abdomen. So this is why rectal cancer is different from malignancies of all other parts of the intestine. Resection of the anal canal is something which any patient hates. Nobody wants it. So what are the principles of surgery in the case of malignancy of the rectal cancer? Number one, now remember, this is very, very important. You must be able to understand what I'm talking about here. Radical excision of the rectum. Radical excision, what does it mean? That means we excise the tumor together. This has to be done en bloc. That means continuous. You cannot remove the tumor and then go for the other things. They has to be done at the same go. En bloc removal of the tumor. Proximal, distal, and circumferential tumor-free margin. That means what? That means if the tumor is over here, there must be a proximal tumor-free margin, there must be a distal tumor-free margin, and there must also be a circumferential tumor-free margin. Very, very important. In the form of total mesorectal excision with lymphovascular clearance. That means the blood supply and the lymph nodes has to be removed. It meaning high ligation of the inferior mesenteric artery. What do you mean by high ligation of inferior mesenteric artery? If this is the aorta, and if this is the inferior mesenteric artery going towards rectum, if you remember, this is the left colic artery, right? The ligation has to be done before the origin of the left colic artery. This is called high ligation of inferior mesenteric artery. Now, there are some controversies. I will not go into that for the time being. For at undergrad level, these information are the most important ones. This is all you have to know. Maintenance of gastrointestinal continuity, that's what we want to do if we can, but if we can't, it's not possible. Preservation, the continence, and preservation of urinary and sexual functions. Okay, a lot of things. We do not have enough time today. I think we will need another class to discuss the operations of the rectum, but I will try to show it as simplified as possible. Now remember, let's say this is the rectum and this is the anal canal. Okay, so rectum is usually, let's say this is the upper third of the rectum, this is the middle third of the rectum, and this is the lower third of the rectum. Okay, let's say this is 4 centimeter, this is 4 centimeter, this is 4 centimeter. So in total 12 centimeter. Let's just say these are the 3 divisions of the rectum. Now, if the tumor is over here in the upper third of the rectum, what you will do, an anterior resection. The surgery, name of the surgery is anterior resection. Why it is an anterior resection? Anterior resection because if you look at the rectum, if you have a sagittal view of the rectum is something like this, right? And here is the sacrum, right? So we are doing the resection of the rectum from the anterior portions. That means from the abdominal approach, because we can also do a rectal resection from the posterior approach as well. So this is called anterior resection. So if the tumor, for undergrad level, I will not go into greater depth, as simplified as possible. Tumors of the upper rectum, we go for anterior resection. So proximal 5 centimeter and distal 5 centimeter tumor-free margins. So we remove this, and then what we do, so this is removed, right? This is removed. So now we attach this with this. So there is a colorectal anastomosis and part of the rectum remains over here. Now, if the tumor is in the middle rectum of the rectum, mid part of the rectum, then you have to go for a total mesorectal excision, because if you remember, you have to do a 5 centimeter clearance, right? So this time whole of the rectum has to be excised. So with total mesorectal excision, and anastomosis will be done to colon with, so this part of the colon will be attached to the very lower part of the rectum. Only a small amount of rectum will remain after 5 centimeter excision, but total mesorectal excision has to be done in case of lower rectum and mid-rectal excision, mid-rectal cancers. Now, what happens? What happens if the tumor is in the lower part of the lower rectum or in the upper part of the rectum? Now, look at this. Have a look at this. Let me just try. This is actually slightly difficult, but I will try. For example, the anal canal is 3.8 centimeters, right? Okay. So our tumor is somewhere around here. If you remember, 3.8 centimeter plus another 3.2 centimeter, that is somewhere around here, right? Our tumor, that's 7 centimeter, right? Our tumor is at a distance of 7 centimeter. Now, what we are going to do in this case? Now, remember that we have to do a proximal and distal circumference, distal clearance of 5 centimeter. But if you remember, whenever the tumor, the rectal tumors always spread upwards, not downwards. The lymphatic spread is upwards. So in case of lower tumors in the lower rectum, we have a different rule. We do not follow the 5 centimeter rule. We only remove distal 2 centimeters. 2 centimeters. And above, we do the whole transrectal excision. Sorry, transrectal, we do a total mesorectal excision, but distally we only give 2 centimeters, not 5 centimeters, because we want to preserve the anal canal. We want to preserve the anal canal, right? So we do not follow that rule of 5 centimeter distal clearance. For upper rectum, we go for 5 centimeter clearance. For mid rectum, we go for 5 centimeter clearance. But in case of lower rectum, we only go for 2 centimeter clearance. Why? Because we know that spread, the lymphatic spread or other types of spread only happens upward direction, rarely downwards direction. So we try to do a distal resection at a level 2 centimeter distal to the tumor. So if it is in the upper part of the lower rectum, that means 4 centimeter. So even after removal of 2 centimeter, we may have 1 centimeter left, right? Or we may not have anything left. We may have only the anal canal left, right? So in this case, we remove the whole rectum with total mesorectal excision, and we only have the anal canal and the colon, right? The colon is over here, the sigmoid colon is over here, and the anal canal over here. So what we do, a colo-anal anastomosis. This operation is called ultra low anterior resection. So what are we doing here? Let's see if I get some space. So if the tumor is in the upper third of the rectum, we go for anterior resection. If the tumor is in the middle third of the rectum, we go for low anterior resection. Okay. If it is in the upper part of the lower rectum, we go for an ultra low anterior resection. But if it is in the middle part or lower part of the rectum, lower part of the lower rectum, we have to go for abdominoperineal resection, because in those cases, we cannot even get that distal 2 centimeter clearance, and the tumor has invaded into the sphincter muscles. So we go for abdominoperineal resection. So now it's simple for you to understand. Upper part, anterior resection. Middle part, low anterior resection. Upper part of the lower third of the rectum, ultra low anterior resection. Lower part and mid part of the lower rectum, go for abdominoperineal resection. I think this is the most simplified way I can make you understand at the undergrad level. But for simplification, always remember, at undergrad level, you don't have to talk about all these things. What you are going to say, Sir, if I can with my finger which is 7 centimeter in length, and if I can palpate the tumor with my finger, that means the tumor is in the lower rectum. That means the tumor is in the lower rectum, and we have to go for abdominoperineal resection, right? If you cannot palpate, then you say, I have to go for anterior resection. I do not think in the undergrad level, no examiner will ask you what are the different types of anterior resection and how you're going to do it. There is again another way of describing this anterior resection in relation to the peritoneal reflection, but those are very complicated. I will discuss this maybe in another future class, but today we are running out of time and everybody is very angry with me. So thank you so much for your time, and have a good day.